pediatric prepared RN, but I'm also heavily involved in pediatric research together with advanced practice nursing role implementation. So this is my main specialty here. Today I will present to you my recent publication, but this work has been running for almost 2 years now. Before, when I was doing my PhD, I was looking into children with chronic illnesses in general and how they cope with the disease and how the disease affects their cognitive functioning, the school functioning, etc. And then we started looking at adolescents and how they are ready to transition from pediatric to adult care. I initially started this concept with, I studied this concept with kids with renal failure initially, and then when I came back to Saudi Arabia, I wanted to apply the model in other disease population, which was type 1 diabetes. The reason why is, to begin with, we have a special children's hospital in National Guard Health Affairs, and there's a big department for diabetes. Also, the increasing prevalence of type 1 diabetes among children in the Gulf region and in Saudi Arabia specifically. I wanted to see how these kids are prepared to transition to adulthood, given the differences between how they receive care in pediatric settings compared to how they receive care in adult settings. And to be honest, this was, the whole idea started, a friend of mine brought this idea in my mind because she was a type 1 diabetes child, and then one time we were discussing the transition, and then she mentioned to me one of her experiences when she first stepped in the adult clinic, when she first was transferred from the pediatric physician that she is very familiar with, and she moved to the adult clinic. She said from the waiting area, she was at that time she was 16 years old. She said from the first step in the waiting area, I was terrified because I was never came to realize the long-term complication that I might face with type 1 diabetes anyway, because I thought I'll be young forever and I'll be healthy forever. But when I went to the pediatric, to the adult clinic, there when she saw the other types also of diabetes, like type 2, where adults come with other comorbidities, and she saw patients who are already with renal failure, others with amputated legs, etc. And then she was shocked that this is now the type of population I am becoming, and this is different. Imagine her shock with, she was never prepared for that. She would always go to the pediatric clinic, they're pampering and taking care of kids and family centered care, and then all of a sudden she's alone in that adult care waiting area with people of older age groups with comorbidities. And that's when I realized how tough it is, that period. Let alone in Saudi Arabia, we transfer kids way earlier than any other countries. I don't know if you're familiar with the US systems where I was trained. Pediatric would continue to receive care in pediatric settings until they are 24 years old. Imagine. So they will go through adulthood, their teenager period and through early adulthood, and they are still with their pediatric provider. However, in Saudi Arabia, and I'm not sure in Takhasusi how is it like, when is the age for transfer, but in National Guard, for example, officially and on paper, the transfer age is 14. So just because they're physically balighin, I would say, or physically mature, or they are able to reproduce by that age, that doesn't mean they are really ready to be transferred to adult care. However, we still do that. What happens usually is that the physician themselves, like for example the pediatric endocrinologist, they will choose to keep the kids with them until they think they're ready. So sometimes you will see kids who are 16 or 17 are still receiving care from the pediatric clinic, and this is because the physician advocated for that or asked the administrator to please keep him for a while. I will let you know when to transfer them. But officially, they should be transferred by 14. For all this play a factor in the transition period. And also keep in mind, we don't have formal transition services in place, not only for type 1 diabetes, but for any other chronic condition facing children. So that was the history of the research idea. Okay, can I go back? Yes. So I just want you to see the incidence or the prevalence of type 1 diabetes in Saudi Arabia and how much it has increased from 2000 until 2021. You can see in 2000 we have only 0.5 case per 1,000, and it jumped up to 2.7 cases per 1,000. So this is a huge number, making us on the 6th highest number of children with type 1 diabetes after India, USA, Brazil, China, and Russia. So that means we will be dealing with a lot of kids transitioning to adulthood. Are we ready? Do we have a system that is ready for them? No. Why is it a problem? Why do you think transition care is a problem? Because in that period, a lot of changes happen, and it all directly affects their adherence, treatment adherence, and it all directly affects their hemoglobin A1C, leading to disease progression and increased risk for complication, etc., which is something the pediatricians were trying to avoid throughout the process. But only in these 2 or 3 years of their transition, a lot of things change and they deteriorate just because of the lack of transition or readiness. So yeah, unfortunately, we don't have any formal services providing transition readiness. Transition readiness in general is about 2 aspects. One of them is increased adolescent responsibility and decrease parent involvement. So we want that to happen. We want to see that child or that adolescent in a level where he is more involved in his care independently, and there is this involvement from the parent side. This is not the case, unfortunately, especially with kids who are, diagnosed with a chronic condition from an early age. Usually parents will be extra protective. So normally this process would be delayed anyway. Imagine with a child who's not anymore with the pediatric team, they suddenly went to adult care. And also, you know how adult care is provided. It's usually patient-centered, unlike in the pediatric, where we focus a lot with the family and the caregiver. So unfortunately, we just transfer them. We don't know if they are ready or not. And I think a lot of this will fall back on the parent eventually. So the aim of the study was to assess adolescents' readiness to transfer from the pediatric to the adult care. We also wanted to look at their perceived barriers to adherence, and we wanted to assess their glycemic control and the relationships among these factors. So again, I know we're both hungry, me and you, so I will repeat that I am studying 3 variables here, because it's a big study and it might be confusing when I go through the results now. So I'm studying readiness, adherence or perceived barriers to adherence, and glycemic control. So the design, it was a qualitative study. We used a cross-sectional design. So this is the first time we look into these variables, so that was the best design to use. We have 83 participants. We included their parents and their care providers. The tools, I used one tool to measure readiness. That was, we also translated the tool in this study, and we have the treatment barriers tool. We also looked at hemoglobin A1C. Okay, those are my demographic characteristics. We have the mean age of the children was about 13, so they are almost ready to officially be transferred. They are around the official age of transfer, which is 14. I just want you to see that here we have Majority of them are using multiple daily injections rather than insulin pumps, which is something we will correlate with a lot. Those are the parents, or the providers. I have 16 providers who were able to participate with us. So each survey has, the readiness survey has 3 versions, one to be completed by the parent, one by the child, and one by the provider. Same thing for the treatment adherence. So that's one of the strengths of this study, that we were able to look from a different perspective. Okay, here are the linkage. So what we found is, so hemoglobin A1C was not actually related to barriers to adherence per se, but it was strongly related to readiness to transition. And it was surprising to us, because you would assume that perceived barriers will be the one leading to poor adherence, but it was actually the readiness itself that was related directly to adherence. So if they are prepared well, they will deal better with the barriers, and they will have better hemoglobin A1C, and not just the barriers itself. So what we're trying to say here is that if you are trying to build a program for transition, you need to focus on the two of the readiness to transition as well as the perceived barriers, not just the barriers itself. So here are some of the domains for that they perceived as barriers. They have some related to disease frustration, things related to disease regimen, medication regimen, related to ingestion or injection issues, and dependence on parental reminders. And both parents and teens reported a higher number on those, indicating that they are perceiving higher barriers to adherence. This is the readiness tool. It's a little complicated tool, to be honest with you, but the main thing is that we're looking at here is how much dependence on parents and how much they're depending on themselves. The numbers are really not good looking. They're still depending a lot on their parents, and indicating an overall low readiness for this age group. If you see here, when you ask the parents and the teens and the provider to indicate how much they are ready to be fully responsible for their care, you see how many are ready. Only 20%, and which is reported by teens themselves. But if you look at the parents and the caregiver or the provider, there is only about 5% out of the whole population are ready for transfer. Same thing for independence in responsibility. So this is not looking good if we think that we are transferring them soon to adult care. And this is the model showing you how or which of the study variables that we looked at really predicted readiness to transition. We have barriers, we have disease duration. The longer the disease duration, the better they are prepared because they're accustomed to the condition, and having a family history of type 1 diabetes also. So I think how am I doing with time? Yeah, so I have 1 minute. So a lot of the findings we have, we're in agreement with a lot of previous studies. Also, we identified that hemoglobin A1C in our sample was higher among male teens, and that perceived barriers to adherence was lower among female teens. Teens who are using pumps rather than multiple daily injection were doing much better compared to the injections. So I think I already discussed all these points, but here I'm just showing you how much we are a lot in agreement with the literature, which supporting that we really need to build our transition programs, looking into how to prepare these kids for transition. Our limitation were that Some of the tools were not diabetic, specific for diabetes, to be honest. And what else we have? Some of them. Let me see. Yeah, we were not able to really test for causality because we did a cross-sectional design, and we technically have a small sample size for the many variables that we looked at. In conclusion, again, to maintain continuity of care and maintain adherence in this population, and also to promote growth and development and help them transition to adulthood as healthy as possible, national transition programs are really needed, and not just for type 1 diabetes, but I think for all chronic conditions. And thank you very much. I'll be happy to have any questions.